Okay, so we're a few months or a few minutes afterwards, and it looks like it's slowed down a little bit in terms of participants joining. So, Melissa, would you like to take it away?
Sure. Thank you, Brenda. Good afternoon or early evening, everyone, and welcome to the first listening session on the Innovation Partnership Fund. The Commission is holding 3 virtual listening sessions around the Behavioral Health Services Act Innovation Partnership Fund. This initial listening session will focus on gathering stakeholder feedback from behavioral health clients and other individuals with lived experience to support the Commission's development of the IPF grant design. My name is Melissa Martin-Millard, and I have the honor of welcoming everyone to this session. Thank you so much for your willingness to participate and provide your feedback. Your insight and engagement will be instrumental in helping us to develop thoughtful, forward-looking, and engaged, responsive strategies to strengthen our IPF efforts. I'm just seeing that our Commissioner Gary Tsai just entered the room. And at this time, I'd like to acknowledge that we do have 2 commissioners here in their official capacity as commissioners, Commissioner Gary Tsai, and also Commissioner Rachel Chambers. They are here to listen to the input and feedback that you all have, but can also dialogue and participate in the conversation. Unlike our traditional Bagley-Keene meetings, while we have an agenda, we really just are meaning for this conversation to be an open dialogue. I want to welcome and turn it over to Sarah Brooks, who's a senior director at Sellers Dorsey. And she's going to facilitate the conversation and walk us all through some slides that were made available yesterday evening to just kind of ground the conversation and the dialogue. But we really just want to hear from you. So you'll be able to raise your hand. We have staff who is tracking who would like to speak. And we'll try to call you in the order that we saw your hand raised. But if you haven't been called, just keep raising your hand and we'll make sure that we give everyone space and the floor to share your input. So with that, we have about 2 hours together. So without further ado, I'm going to turn it over to Sarah Brooks to move to our next agenda item. Sarah?
Great. Thanks, Melissa. Good evening, everyone. As Melissa said, my name is Sarah Brooks, and I am a senior director with Sellers Dorsey. I am pleased to be here this evening with you all to be discussing the Innovation Partnership Fund with you all. All right, we'll move to the next slide. Okay, and we can skip this slide too. Okay, so we wanted to start off with just laying a little bit of information out about the Innovation Partnership Fund and just the timeline that we're on. As you can see here, this slide presents a timeline that shows between July and October of this year, 2025, that we're in. We've had a couple of meetings so far. We had a program advisory committee meeting recently where we presented a version 1 of the Innovation Partnership Fund document that since has been updated to version 2, which is posted online. Some of you may have seen that and reviewed that. We'll be presenting on concepts of that today and welcome your feedback on that, as Melissa said. We are in the virtual community engagement session period and lived experience period session, or excuse me, lived experience session period. Now, and you can see that those meetings are laid out here between August and September. And so we'll be going through those meetings in the next couple of months here. And that then leads us into the program advisory committee meeting, which will happen in September, where we will present a version 3 based on all of the great feedback that we received from you all today and in the next coming sessions. and also which will include a program design. And then updates will be made to that based on the committee meeting discussion, and then a final presentation at the commission meeting following that. Next slide, please. I guess there's some pop-ups on. Okay, there's pop-ups in everywhere, so we can just bring up all the pop-ups, yes. So we've had a lot of discussion so far already with members of the community, but wanted to continue, obviously, as we talked about today with the lived sessions. So, but what we've heard so far, we wanted to kind of communicate to you all and share. And so thank you. Sorry about that. I guess when we get a little fancy, things happen here. But wanted to share with you kind of some of the things and the feedback that we've heard. One of the main things that we heard is really that the IPF needs to be community centered. And I think we would all agree with that. You'll see here on the slide, there are other terms, other words that we have heard from you all: access to treatments, data-driven, transparency, peers, technology. These are all themes and things that came out of the discussions that we've heard from the community thus far in our conversations. Next slide, please. All right, so we're going to talk a little bit about the target population and the project purpose. Before we get into this, I do want to kind of highlight the fact that this information has already been landed on. So the legislature has put in place, and I think we can move it forward because the slide's not populating everything, sorry. The legislature has already outlined in statute who these populations are. And so the target population itself, the target populations themselves are outlined here. So we've got children and youth who satisfy one of the following, and you can see the bullets are listed here: are chronically homeless, or experiencing homelessness, or are at risk of homelessness. Won't read all the bullets to you, but are or are at risk of institutionalization. Those are examples of children and youth. Then we also have adults and older adults who satisfy one of the following. An example of those are in or at risk of being in the justice system, or are at risk of conservatorship. Next slide, please. With respect to kind of project purposes, you know, the overall kind of project purpose here is with respect to what the IPF is doing is really around focusing on improving BHSA programs and practices for the following groups. So focusing on underserved populations, low-income populations, communities impacted by other behavioral health disparities, and other populations as determined by the BHS Oversight and Accountability Commission, excuse me. So really meeting statewide BHSA goals and objectives. And again, as these things are outlined in Welfare and Institutions Code, section 5845.1, as is outlined on the slide here, if you want to go and take a look. All right, next slide, please. So we know that we need to define innovation, and that's something we can go back one slide, please. We know that we need to define innovation, or forward one more slide. Sorry about that. I don't know what's going on with the slides. Oh, I think it's missing a slide. We need to define innovation. There.
I think you're thinking, Sarah, the one slide forward.
Oh, am I?
Yeah, I'm guessing, because there's the project purposes, and then so this brings it all together, and then you're about ready to talk about defining.
Oh, I'm
innovation,
sorry.
right?
Okay, sorry.
No problem.
Thank you, Brenda, for helping me. Okay, so project purposes and continuing. Okay, so with respect to Proposition 1, just real quick, a note, and thank you, Brenda. I'm sorry, I got off track with the slides. Proposition 1 must be directed towards these populations with the highest behavioral health needs who often face structural barriers. So this is language that was added to version 2, and so just wanted to highlight it because it was feedback that we received from the community, and so important that we added to it, or added this to version 2. And so wanted to kind of highlight it and make sure that you all saw that we had included this, and that it was included, that we ensured to make sure to add it to the document itself, and to the overall context and construct of the IPF. So sorry that I got off on my slides there. All right, next slide, please. We're back on track. Innovation. All right, So with respect to innovation, and we can go one more slide, there are 4 bullets here that really kind of outline the different kind of components of innovation. And this was one thing that we heard largely from the community, is that we needed to define innovation. And so, you know, I really hate to read slides, but I think this is super important, is for us to go through and understand what each of the bullets says here, because we're going to have a discussion after this. The next slide really asks questions about, what do you think resonates here with you? What doesn't? What do you think we should change? What don't you think we should change? And so want to get into the weeds here with what's listed on this slide. So with respect to kind of the first bullet, we have advanced new models, tools, partnerships, or technologies not yet widely implemented in California. This may include adopting or scaling efforts underway in one county, but that could be scaled in other counties. And I wanted to kind of highlight here that this is an opportunity, or this is a place where we did make a change last time from version 1 to version 2, in that we didn't have changes from one county, but that could be scaled in other counties in here before, and that was language that was added. So that was a change that was made. The second bullet, introduce or scale practical community-centered solutions that increase access to prevention, treatment, and recovery supports, particularly for historically underserved populations and inclusive of harm reduction approaches. And so just want to note that this has community-centered solutions, which include but are not limited to community-defined evidence-based practices. Third bullet, demonstrate a clear break from the status quo, not simply incremental improvements to existing programs or efforts, but a concerted deviation from those efforts. And the fourth bullet, to be actionable and ready for real-world implementation, not solely focused on concepts, research, or pilot testing. Innovation itself may include ideas from other sectors or geographies, adaptation of promising practices, or bold new models co-created with people with lived experience. At its core, innovation is about transforming how we deliver care with impact, equity, and dignity. Now, one thing I do want to note is there was another bullet here previously that talked about supplanting, and that has been removed from the slide, and so no longer is it included. It discussed supplanting or not allowing supplanting of dollars with these funds, and so we have removed that. All right, so let's get into a discussion here. So let's look at what the questions are. Next slide, please. All right, so as I mentioned, we really want to talk with you about whether or not the definition resonates with you, and really what would you change about the definition. And I think we can go back to the slide before, just so it's listed up there so you all can see what the bullets look like. But that gives you a sense of the questions that we're looking for, and really want to open it up for dialogue now with you all, so we can hear from you all about what your thoughts are in terms of the definition of innovation. So turning it over to you. And I cannot see if there are hands up, so I'm not sure.
We're scanning.
Yep. If you would like to make a comment, you can go ahead and use the raise hand icon at this time.
It looks like we're starting to get hands raised.
Okay, the first one I'm going to call upon is Kevin Dredge. Kevin, you may speak. Your line is unmuted. Please unmute the line on your end.
Hi there, are you there?
Yep, I think we can hear you.
Oh, wonderful, wonderful. I was just wondering, I'm in a little rough location. Is it too windy out here, or is it going to be okay?
I can hear you clearly, Kevin.
Okay, wonderful. Well, I just wanted to thank you very much for being here and doing all this hard work. And I just getting a chance to look at the revised definition here, and it looks great. Just if we can just come up with a way to track this and measure that, and really kind of put in some trackable results to see how things are going.
Great.
That is great. Super helpful comment, and we appreciate it. I think tracking and measuring is Brenda, and that's right up our alley. Looking forward. All right. Next comment, please.
The next comment is coming from Kim Stafford. Kim, your line is unmuted. Please unmute on your end.
Hi, I'm just jumping into this for the first time. I read the materials, and you know, my mind kind of goes pretty quickly. And what I'm thinking is, you're going to have all these guidelines. Basically, that's what you're putting forth: definitions and guidelines of what's to be considered in a proposal to advance these objectives. Is
Yeah.
that?
Oh, I'm
Yeah.
sorry. Go ahead.
Yeah. In reading the entire format, I thought it was seeming a little bit complex. You know, innovation is, you know, taking the objectives and the implementation process. I guess my question is, who is going to be, how is this process going to be implemented? In other words, are you looking for people in the community that can identify inequities in service delivery to write proposals, or are these funds already earmarked? You know?
Do you want me to take that one, Sarah? Or?
Sure. Go ahead, Brenda.
Yeah, happy. And I'm Brenda. I'm the executive director for the Commission for Behavioral Health. So thanks everybody for being here today and appreciate the dialogue. So essentially, we have this $100 million 5-year allocation for innovation partnership funds that we will receive on July 1, 2026. And so right now we're in this planning phase to figure out what will those projects, what will those grants look like. And so right now we're in an information gathering mode to get ideas on everything that we should be considering or thinking about as we start putting this grant concept together. And so right now we've had some conversations, actually many of the conversations started last year with the commission and have continued on through this year. And right now we're in the phase of these stakeholder meetings to get community feedback on what should be the considerations for when we're developing this grant concept. So what Sarah's gone through here so far is just a definition of innovation. That's something that our stakeholders said was really important to do, is just even say, what is innovation as we're thinking about how we're developing this grant concept. So we're going to have these stakeholder meetings now through the rest of the summer. And then in September, and this is a little bit kind of jumping ahead because I think we'll wrap this up towards, I think, the end of the slide, but maybe, or the presentation, but it might help everybody to anchor thinking. So we'll take all the information and all the feedback that we've received over the last year and on in through the summer and develop a grant concept, a draft grant concept that we will talk about at our September program advisory committee meeting. And then from there, take input and present the grant concept to our commissioners, our 27 Commission for Behavioral Health commissioners in October. And if that gets adopted, then in January, we will present a request for proposals outline. And if that gets adopted by the commission, we would then right afterwards in late January, early February, release the request for proposals. And then whatever organizations will apply. And then we're looking to begin contracts in July 1, 2026. So hopefully that kind of lays out the game plan. So barring any unforeseen circumstances, that's how we've drafted it out right now, but we're still very much gathering input to even develop the grant concept. So does that help answer your question, or at least anchor your thinking, Kim?
Yeah, it helps. My other question would be, can a community-based organization such as a wellness center apply for the innovation grant? Is that who would potentially apply for it?
It could be a variety of organizations. So, yep.
All right, thank you.
Yeah. Good questions, Kim. Thanks for asking.
Thank you, Kim. We have two more comments. The next comment is Rhea Garrett. Your line is unmuted. Just please unmute on your end.
Thank you. Good afternoon. My name is Rhea Garrett from Strides, and a couple of questions I had just to center my thinking. One was, it says here, well, first of all, is this grant available to just nonprofits, or is it available to for-profit organizations as well?
Yeah,
Are able to apply as well.
Okay, and in the definition or the target populations, the categories were kind of wide: children or youth, and adults and older adults. And I know that they broke that down a little. And I wonder, does the adults or older adults, does that include reentry populations and specialized populations like sex offenders?
yes, it would be all justice involved.
All justice involved?
Yeah, so if you go back a couple slides, Grace, would you, or I don't know if Grace is doing the PowerPoint, but if we go back to the priority populations, one more slide back, there you go. So when you look at the adult and older adults, are in or at risk of being in the justice system.
Oh,
so
perfect.
It would cover anybody in the justice system who has a behavioral health needs next as well.
Right. And my final question, I know I said two, but the third question is, in that slide where they were defining innovation, and it said, like upgrades or improvements to existing evidence-based practices. I'm sorry?
Sorry, I just want to make sure we move forward to the slide you're talking about, back to the innovation partnership definition slide. Okay, go ahead, Rhea.
Prayers for the slide person, because I know we're driving them crazy. Okay, so it says here that it will, including community-defined evidence-based practices, but then in the next slide, it goes on to demonstrate a clear break from the status quo. So do you want programs that are going to be based on current evidence-based practices in the community, or are you willing to consider something that's never been done before, even though there's no evidence to prove that it could work?
I think that's what we're gathering input on. So I think, is that a recommendation that you have, is to consider, and it is kind of been covered in the first bullet, advancing new models.
Okay.
Mm-hmm. So is it covered there, or do you think it needs to be more explicitly clear?
Well, no, I just said, I felt like it was saying two things at once, that we're going to advance new models, but at the same time, we're going to scale practical community-centered solutions, which have already been proven, but we know that they don't necessarily always work for everyone.
Yeah, exactly. And that's, I think, what's come up in the conversation is that it's, it's not just new models, but there are things that maybe have been developed and tried and found to be effective in one area, but we don't know if it's going to be effective with another area or another population. So that was some feedback that we had early on, and had kind of written it up to allow for both.
And I
Thank
think,
you.
Brenda, that this slide, the word "and" on here could be confusing, in that all four of these bullets don't have to be done together. Like these are separate standalone bullets, right?
Yeah.
They're
It's ORs.
concepts that are standalone separate bullets. So that may have been confusing. So
Yep,
that's a great question.
Mm-hmm.
Okay, looks like we're going to go to our next commenter, Zakaya. Your line is unmuted. Please unmute on your end.
Hi, this is Zakia Otis with San Bernardino County, and my question was regarding the timeline for the project. So I know that this innovation, the funds are available for 5 years. So when submitting the proposals, are you looking to only have the project for 5 years? Like, is that the total amount of funding? It's not going to be able to be renewed at a later time, or like what? Because under the current MHSA, every year we had an allotment that we would be able to, use innovation funds to promote different projects. So is this just like a one-time, if you can figure it out and get it approved, then use some of the funding, or is it like, how is that?
That's a good question, especially talking about the changes. So it is one-time funds, and thereafter it would be subject to the regular annual budget process. So we would have to go through the regular state budgeting process to ask for more funds. I think the idea is to see these innovation projects go through and see how things are going, and then revisit at that time to see kind of what would move forward.
So it would be, you'll release it in 2026, and then not till 5 years later, you would consider opening it up for new innovation projects?
It wouldn't be a matter of us opening it up. We wouldn't have an allocation to do anything more. We would have to go to the legislature and administration and request the funding for more ongoing funding, or more funding, I should say.
And this is statewide, like everybody in the state is going to be competing for the same $100,000,
Correct.
100 million, yep.
or
Oh,
100 million, sorry. Sorry. Yeah.
Thank you. Yep. Yes. Well stated.
Okay, our next commenter is Laurel. Laurel, your line is unmuted.
Hello, I'm wondering why I can't unstart video.
I don't think we have, yeah, go ahead, you guys.
I think that's one of the things we've set up on our end, so apologize for that.
All right, thank you. My name is Laurel Ben Hamida, and I'm been a long time part of Muslim American Society Social Services Foundation out of Sacramento with a statewide reach, and REMCO, the Reducing Mental Health Disparities Coalition. I see that you're looking at the proposed definition, but the questions that you've been getting are similar to those that would be given, that one would get at a proposer's webinar after an RFP. Do you understand what I'm saying? The previous few questions. And so I'm going to ask one of those questions too. It seems to me a bit confusing, probably, especially for people who aren't familiar with this as it's been evolving, that you have on the one hand a list of underserved, low-income populations, communities impacted by other behavioral health disparities, and so on. That's on one slide. That's the IPF project purposes. But on the other hand, there is the statement elsewhere, I'm flipping through to find it, that yes, on the back side of this piece of paper, the project purposes, this new section, that these provisions require per Proposition 1 that all funding has to go to populations with the highest behavioral health needs. So I'm wondering, by that, do you mean, for example, the kind of population that's defined for involvement in potentially in care courts? So those with schizophrenia, those with schizoaffective disorder, and maybe with new legislation, opening it up also to bipolar with psychotic features. I think if we don't get this defined, a lot of people are going to be wasting their time on these calls, because that is a pretty narrow number of people within the larger populations of underserved and so on. Am I clear? Am I
Yeah,
making?
yeah, it's very clear, Laurel. Thank you for asking, because I think there has been some or quite a bit of confusion on that, because especially from the way moving from MHSA to BHSA, and in BHSA, all this is mapped out in the statute. Oh, can you hear me?
No, I can.
Okay, so it's all mapped out in the statute. So the statute that allocates the Innovation Partnership Fund dollars points to the priority populations. So there's a reference from the IPF statute that says you'll serve the low income, the different populations as it relates to these BHSA priority populations that the counties are now mandated or clearly mandated to serve. And to your question, in terms of like things like somebody with a diagnosis, like somebody can have those diagnoses, but not necessarily be high needs. So it's the high needs aspect of it that is really the focus of these funds.
So following up, I think one of the things that I thought was, well, the kinds of diagnoses that I just listed, that CARE Court and Prop 1 were focused in on, you don't find among children and youth below the age of 15 or 16 in often. Those schizophrenias are more often seen in the later teens. So I think that's an added confusion that would help us all if you would clarify.
And it's not just those folks. Those folks can be included, but if we go back to those priority populations, it does have children and youth who would be at risk of, who are at risk of being in the justice system or going into the child welfare system, or at risk of institutionalization, and then also the homeless piece component.
So they don't have to have a diagnosis.
It's not diagnosis driven.
So I believe that more clarity is needed.
Okay.
Or you will have a lot of people who've wasted their time, and you may waste your time reading things that are just way off target.
Okay. And it's really the nature of it's being high needs populations. So these are all high needs populations.
So but isn't clear enough yet.
Okay.
I imagine.
So we'll work on getting more clarity on that.
Yeah. And I guess the thing, for example, in our organization, we have many families with more than 1.5 children per family, much more, who are victims of conflict zones, war, trauma, journey, resettlement, re-traumatization. And so, but they may not be anywhere near a diagnosis of the kinds that you mentioned. So you're saying this is not diagnosis driven.
Correct.
That we can work ahead on a proposal that meets everything else that is mentioned in these papers, and we'd be on safe ground.
Yeah, and maybe to even be clearer is it's not diagnosis driven. Those are just examples that are from in the paper, because folks are actually, the opposite problem is happening, where we're seeing those folks with those diagnoses or in the SMI who are high needs being left out of different projects coming in. So the goal is to try to get more folks who do projects in this, because that hits the target population. But to the extent that it's high behavioral health needs is really the point.
Well, one of the things that we know about refugees and immigrants and all people who have had trauma is that post-traumatic stress syndrome is best treated early on, but best prevented, but early intervention and treatment has the best outcomes. And so I could see that being something that would be important for many organizations, not just ours. There are other immigrant populations who, have these issues.
Yeah, thanks, Laura. And I was just going to say, kind of to the other part of your question in terms of, would we be safe in the grant? This is actually the whole point of this is to develop the grant concept within the requirements of the allocation. And so really putting the target population, and then the next slide that has the the additional program requirements, funding requirements, is to really anchor that this is who we're talking about. So to the extent that any of that would fit into this framework or how we're thinking about the concept is what we're looking for input and feedback on.
That's very helpful. Thank you. I think the more clarity you can establish, the more efficient the process will be. I guess my other question will wait until you've gone on a little more.
Okay, thank you, Laurel.
You.
Our next, Paul, I'm unmuting your line. Please go ahead.
Years ago, initially when the Mental Health Services Act passed, there was an innovation committee, and perhaps we could look at what they came up with for a definition and go from there.
I believe that was inspiration for this, Paul.
What's
Good
that?
to hear from you. I said I believe that was part of the inspiration for doing this, and I think there was a lot of struggles with defining innovation for that. I wasn't here at the commission at that time. I don't know if any of my team members can weigh in on some of the previous innovation conversations, or how maybe some of the work that had been done to define innovation through MHSA has been applied here. So if it, can anybody chime in on that? So,
all right, thank you.
You're making a good point. And good to hear you.
Karen, your line is unmuted.
Yeah, thanks. I have two comments. I really want to say that I agree completely with what Laurel said, because I'm looking at the sort of examples you give further on, youth prevention and early intervention at a population level, right? Like that's so different than focusing on these very specific youth. One of them, ensure youth voice and leadership in program design. Like that's so very different than focusing on youth in the juvenile justice system. So I would encourage more clarity around that. But my comment was on the slide we're supposed to be commenting on. The fourth bullet point says,
let's move forward so we can follow you, Karen.
Yeah, be actionable and ready for real world implementation. That to me, I mean, this is innovation, right? So this is Karen Vicari from Mental Health America of California for some context. And I look at these and we work with a lot of groups that would have a lot of great ideas, and they're in process on these ideas, but they're not ready right now to be launched. I feel like innovation is, if you want to be innovative, then you would maybe fund people with a great idea who are working on an issue, but give them a little funding to fully develop that, as long as it sounds like a promising idea. So I would, if it was up to me, change the fourth bullet to make it just a little more wide open. That's all. Thank you.
Thank you. Next commenter, Marin, your line is unmuted. Please go ahead.
Thank you. My comment is for the first bullet. It's advanced new model instead of new models. Maybe we can, because great, ideas, innovative idea could be in existence. So maybe we can change it to advanced pioneering models, tools, partnership, or technologies that consistently drive effectiveness and deliver transformative outcomes. And that way there are measurable outcomes, rather than, just new model, which we don't know exactly what they have delivered or not, the positive outcome, so that it's more precise.
Do you think, Marin, just kind of going off of that, the second bullet, is there something that could, like edits that could be made to that? 'Cause I think that's what we're trying to get with the second bullet there.
What did you say? I'm so sorry. I didn't hear your
Yeah,
question.
sorry, Maren. I was saying the second bullet is what we were trying to get at that, you know, there's some things that have been tested before, and then trying to scale it to different places or other, you know, it's like, so trying to
I
scale
love the
this
second bullet
Yeah.
as it is, because it
Okay.
speaks to the community-centered solution, consumer-run organizations. So I think that's different than the first one. The first one, to me, the way I see it, it's very broad and vague. And maybe we can just at least have some qualifications that at least they're consistently drive effectiveness or deliver some outcome. I think that might be helpful. That's all. But I love the second bullet for sure.
Okay, I didn't know if you had any ideas for the second bullet too. And I think for the first bullet, it actually is trying to do something absolutely new. And so that was one thing that we had gotten feedback on is, you know, to allow for that. So kind of maybe going back to what Sarah was saying earlier, and was that question about these are ors, not ands. So so these would be like four different, like you could do new things or scale it. There'd be projects that would be allowed for either. So I'm just trying to think how we could, like, is it covered, or because technically for that first bullet, it might be something that's truly new and we don't know what the outcomes are for it yet because it's new. Oh, did we lose Maren? I don't know. Is just before we move on, I just want to see if there's, given that, do you still have concerns about one that truly is new?
So the only thing, I mean, the only reason I'm saying this, you know, maybe qualifying what new is by adding maybe, you know, that they drive effectiveness, there's an outcome attached to it.
Got it. Okay, thanks, Maren.
You're welcome.
Our next commenter, Jerry Hall, your line is unmuted.
Hi, everybody. Thank you, and I'm sorry I was late. I was in another meeting. I also am concerned just about the introduce and scale question because, you know, it seems that our innovation fund just got cut from something over 120 million. If every county was using 5% of their budget for innovation, it'd be about 120 plus million. And now we're down to 5 million. And my concern is using these funds to scale things that may get otherwise funded because they're already operational and they're attractive to investors, for instance. If we're going to, you know, have a fund that is looking for new ideas or new ways to approach things, it just seems like the limited amount of money should be focused on that facet rather than scaling. And scaling could be, I understand the word scale, but in the traditional entrepreneurship model, scale means you went out, you innovated, you improved a process or something, and then now you're gonna, you know, throw a lot of money at it so you can get 100 times the results. That's attractive when something is, you know, a prenatal program for Black women, for instance, in an inner city community. That's great if it's, you know, it's helping 30 people and you want to help 300. That could be innovative. But so I'm just concerned about the if we're going to use the word scale, then you choose another word and then talk about, you know, if there's an existing proof of concept out there, if you want to scale that. But the word scale is traditionally used as you've already proven everything and now you want to multiply your results. Thanks.
Thanks, Jerry.
Okay, that looks like that was our last commenter. And I just wanted to inform everybody that we did make some technical adjustments. So if participants would like to use video, they certainly may do so moving forward.
Great. All right. Well, we received a lot of good input there, and there was some good conversation just about the general concept of the IPF as well. Yeah, and if folks, I can see if folks can go on mute, that would be great. All right, so we'll keep moving along into the next part of the presentation, and we'll go to the pillars. And so there are 3 pillars that have been, next slide, please. There are 3 pillars that are set forth here with respect to the IPF, the youth, workforce, and connection. And you can see here that youth is prevention and early intervention at a population level, workforce, expanding peer, traditional, and non-traditional providers to align with community needs, connection, enhancing quality and integration of behavioral health systems and services. One thing I think that's important to note is that these pillars are inclusive of other populations. And so, for example, we had questions at the last meeting around would youth include LGBTQIA+, I+. Yes, of course. Certainly these are more broad pillars that are more inclusive of other populations as well. Next slide, please. So again, we bring these questions to you to ask you whether or not they resonate with you. So do the pillars resonate with you? Would you recommend we remove a pillar? Is there a pillar you would recommend we add? Again, there are the 3 pillars. We'll pull them up on the slide so we can look at them. Want to have a conversation with you just around resonation and whether or not you think they seem right or you think that we should add anything. So opening it up for discussion again. So we look forward to hearing from you all. And I see a hand up.
Okay, our first commenter, Jerry Hall, your line is unmuted.
Hi, just a quick question. Is this the prevention early intervention at a population level? I was just wondering if the state is taking over the PEI with the, I'm not sure if it's 4% or 3%, but the amount of money they have, it seems like PEI is has some bases covered, and there might be a different pillar to consider, just because if we have such limited amount of money, it seems like they could take a little bit of their PEI money and use that for innovation, and this fund should be used for the other areas. So thanks.
Thank you, Jerry. The next commenter, Marin. Marin, your line is unmuted.
This is more like a question. So under the workforce, when you say expanding peer, are you referring to peer support specialist or just peer?
I think we're just in general, but we would welcome feedback, Marin, if you have some ideas on that. Is there more clarity needed there?
I mean, it would be tremendous if you can add expanding peer support specialists so that it's more specific, at least as far as we're concerned.
Because yeah, there's different kinds of peers that work in these systems. You might have peers working as substance use disorder counselors or peers working as community health workers. And I don't know if Dr. Tsai might not be online right now on that one. Oh, is he back? Hey, Dr. Tsai.
Apologies.
No problem. In terms of, I don't know if you heard the question, but it, okay, great.
Yeah, I mean, we can certainly consider, but I think Brenda does make a good point about the fact that peers can be a broad term. And in general, when we're thinking about pillars, we're trying to make things broad so that we can fit as much as we can under this umbrella, right? Because we're trying to be inclusive and not exclusive.
Understood.
But, you know, we hear your comment and certainly can consider.
Thank you very much.
Thank you.
Okay, our next commenter, Ria. Ria, your line is unmuted.
I was wondering, could you define for me what you mean by pillars?
So I can weigh in on this. When we had started this process, anytime you start something new, if the whole universe is an option, it can be difficult to kind of figure out where best to start. And so that's the reason why we wanted to establish some pillars to try to establish some boundaries, even though, like I just mentioned, we wanted those boundaries to be broad. So we weren't excluding certain populations, right? And so in terms of youth-focused services, workforce, which obviously spans a lot of focuses, and then this kind of general idea of connection, which is really focused on quality and integration of behavioral health, meaning mental health and substance use services. We thought that that was kind of broad. And just to highlight, I know that we've gotten some feedback about specific populations, whether it's older adults or LGBTQI or, veterans, or, the idea is that all of that is encompassed within these pillars, but we don't necessarily want to get into calling out specifics, because then otherwise, inevitably, we're going to leave another group out, and this ends up being not a pillar, but more like an entire building.
Oh, so when we talk about pillars and inclusivity, is there anybody that's excluded from these services that you can think of?
It's a great question. I don't think that the focus, and Brenda and others feel free to weigh in, I don't think the focus has been excluding any particular populations. I do think, though, as we had highlighted earlier, that the statute does require a focus and a prioritization on certain groups, right? And so that's what I would highlight, is we are required to prioritize and focus, but not necessarily exclude any particular group.
Thank you.
I would say, before we move on, Rhea, is there a particular group that you're concerned about being excluded? Oh, can we still make sure she's unmuted?
Thank you. No, I wasn't, but I have several different colleagues that work in several different avenues of service. And I just, as we come together to put something together, I just want to make sure that there's not a group like, oh, that we're not talking about them. So.
Okay. Yeah, thank you. We'll be mindful of that for sure. And I know you mentioned 290s earlier, and that one's always one that gets excluded. So
yeah. So I'm a stickler.
Yep. I hear you.
Thank you. Our next participant, Karen, your line is unmuted.
Hi again, Karen Vicari, Mental Health America of California. We work with transition age youth around the state and LGBTQIA plus populations around the state. And what we hear just by far the most often is access. We want access, and they don't know how to get access. And there are, they believe they have innovative ways to educate their communities on how to get access, especially the LGBTQIA. So I guess I would like to see under connection the word access in there, like access as part of one of the pillars, because it's the largest problem that we see. Thank you.
Thanks, Karen.
Okay, that looks like that concludes public comment. We just have one more that just came in. I'm sorry. Kim, your line is unmuted.
Yeah, under workforce, I just want to put out that I think that it would be good to put expanding peer specialist roles in traditional and non-traditional, with traditional and non-traditional providers to align with community needs.
Yeah, thank you, Kim. We'll certainly take that into consideration. I think it gets into the notion of kind of the more specificity we include in these, the kind of narrower the pillars become. And so it's just a matter of kind of how broad or how narrow we want the pillars to be.
My other comment is that, you have a lot of funding in early prevention with youth and children services. And I'm thinking that the whole purpose of this funding would be something that would be new, that would augment, that also could augment an existing provider.
Thank you, Kim.
That looks like that concludes public comment. I will turn it over to you.
All right, so we will keep moving on our slides. We'll go to the next slide, please. And one more. All right. So we have come up with 6 different priorities, or yes, these are priorities. I think it says proposed pillars. That's a mistake. Priorities in alignment with the goals of the program advisory committee, and those are equity, financing and sustainability, public-private partnerships, lived experience and community leadership, alignment with state efforts, and demonstrate agility and lean process integration. I think that it's important to note we added demonstrate agility and lean process integration following conversations with the community. And again, wanted to open it up for conversation whether or not these are the right proposed purpose. Can we go to the next slide, please? Sorry. Whether or not these are the right priority areas. Do they resonate with you all? Is this a priority area you would recommend that we remove? Or, I mean, are there priority areas that you would recommend we remove or that we add? So again, we'll go back and just look at the priority areas on this slide. These are the 6 that we're presenting to you all for conversation today. And again, opening it up for discussion.
Not seeing any public comment for right now. Okay, we have one. Ria, your line is open.
Thank you. It says alignment with state efforts. Could somebody let me know what that means?
I think it means with the broader behavioral health system and all the different efforts we have underway, there's a lot happening with what's called behavioral health transformation in our state. So we have a lot happening in the Medi-Cal space, particularly with our Medi-Cal County Behavioral Health Department. And so just trying to make sure that whatever we're doing in the Innovation Partnership Fund projects or in these grants, that they are aligning with kind of the broader goals of the public behavioral health care system. So we're not kind of going in opposite directions, but we're kind of rowing together and to really make progress over in the next 5 years in particular.
Well, I imagine that then the thing is the delicate dance that has to happen between trying to create something new and innovative without ruffling the feathers of the efforts that are already in place. Is that accurate?
Yeah, I think we wouldn't want to do something contrary to what's happening elsewhere. We would want to do something that's going to benefit, particularly it's our county behavioral health departments, because in the BHS, the Behavioral Health Services Act, of the 100% of the funds that we capture from the taxpayers, there's going to be 90% that's allocated to the counties to focus on the services for our high need populations, those priority populations. And so really the work that's going to be done under these IPF grants, this innovative work, should be furthering the efforts to be able to help the counties optimally serve these populations.
Okay, thank you.
Does that help, Ria?
Yeah, thanks.
Yeah, okay, good.
Okay, our next commenter is Susan. Susan, your line is unmuted.
Hi, I was hoping that you could give me a description, well, maybe a description of demonstrate agility and lean process integration. That's not a meaningful statement for me. Dr. Sai is laughing at me.
No, I can weigh in. At our last meeting, there was feedback from a couple people, I believe, about the desire for systems, processes to essentially be more efficient, more agile. And so I think the desire here with this IPF funding was to try to support us iterating quickly, making mistakes quickly, but also learning and correcting quickly. That was essentially the feedback that we had gotten. And so that was incorporated in.
Useful, thank you.
Thank you, Susan. Next, we have Laurel. Laurel, your line is unmuted.
Okay, I finally got the right button. All right, so I'm still Laurel with the same organizations. I did just want to back up for a second. I had been confused by the 2 pages that printed out, one with 3 pillars and one with 6. But now I get it. That was
Yes.
just a human error. Okay, no
Thank
problem.
you. Sorry about that. Yes.
So if I could just back up to the youth bullet point, I think the word family isn't used in this document much. And I think for many of the underserved populations, family is really important. And my guess is you haven't had enough of them at the table speaking. Consumers, for example, there are reasons for that. We don't have to go into them now, but I think family would have come out. So that's just a suggestion, and you might want to find out more about that. Go and ask. So on to the proposed 6 pillars. I think that we all need you to define equity, financing, and well, not so much sustainability, but maybe financing, that can lead to equity, can lead to sustainability. I know Commissioner Carnevale has alluded to these things often, and people are wondering exactly what he means, and it's probably time to hear exactly what he means. Because I have a guess that equity is maybe something that he sees as a good thing potentially. And I do know of at least one nonprofit organization that invested in houses in the 70s in the Bay Area. And now when you give them money, nothing goes to overhead because they have equity. And everything you give to them goes to services. That's what I think of when I think of equity, but not on that. This is not what the organization I'm talking about is not $100 million organization or a $200 million organization, so I'd like to hear more.
Yeah, and that's great, Laura. And I'd say in equity here, what we're meaning is that the services are equitable by different populations, so that we're seeing equity for, different populations and groups. So not really equity in property. So
it's not.
So it's interesting you read it that way. So appreciate
it's not
saying
Commissioner Carnevale.
well, probably stuff would fall under that second bullet, like you just said.
Okay.
So,
okay.
but not equity in that sense. It's but I could see how you could put the 2 and 2 together, connect those things. So.
Well, that could lead to sustainability.
Yeah.
But we have to know more because we all know too many horror stories. Promises made, not kept. Yeah. So, but optimism's good. So those are my questions. I think I had to look up lean process integration today.
Great, thank you.
Thank you, Laurel. Our next commenter, Jerry Hall. Jerry, your line is unmuted.
Hello again. Yeah, I'm a champion of the lean process, and that is, rather than building out your full program or service and then delivering it to the customers to see if it works or not, the idea is spend as little as you can to find as much as you can before you spend any more. And the idea is you want to, most entrepreneurs, fail at their businesses. I've failed in several, I've succeeded in a few. But the idea is that you spend as little money as you can on things to find out if it doesn't work so that you can spend, more little money on something else. And the thing I see missing is around data and transparency. And it would be great to see those as pillars. And by those, I mean, giving access to people to the data so that we can see what's happening, and we can play with the data and maybe come up with a hypothesis and go and pitch it at a meeting. But the idea of transparency is, and I think it ties right into equity, is that, you know, we've seen the same old promises, and without, you know, transparency and accountability, it's really difficult to, you know, look back at the last year of the plan and did it work? Did it not work? And you know, if we have access to the data, we can be more, we can contribute to you more on a more informed basis. But without the data and without the timely data, it's really difficult to do. So it'd be great to see some form of accountability here and transparency in it. And it usually focuses on data from my perspective. Thank you.
Thanks, Jerry.
Thank you, Jerry. Next commenter, Maren. Maren, your line is unmuted.
Thank you. I'm not sure, but is there any way we can add or emphasize or highlight a consumer-run organization as one of the pillars?
Can you say more about that, Maren? Oh, can you hear me? So
I think
she's
you're
muted.
on mute, Maren.
There you go.
Can you hear me?
Yep,
Yes.
can hear you now.
I'm not sure exactly how to word it, but highlighting the importance of consumer-run organization, particularly operated by individuals who are consumer of behavioral health themselves. And you have it here, lived experience. But I think the phrase consumer-run organization might encompasses lived experience and community leadership.
Thank you, Maren. Rhea?
Thanks. I was in response to what Maren was requesting. Would it consumer run and peer support and lived experience kind of all be under the same umbrella? Because the purpose of the peer support is people who have lived through the experience of the people they're trying to serve, right? Isn't that the same as consumer run?
I certainly can be interpreted that way. That's the way that I've interpreted it before. I think, you know, I think we're getting into the fact that we can use different terminology to refer to the same thing sometimes, and just a matter of, you know, it is important for us to hear feedback because words matter. So it's helpful to know. And then Sarah?
Sarah, your line is unmuted.
Hi, thank you. My name's Sarah Jean. I'm the Vice President of Warmline Programs at the Mental Health Association of San Francisco. And just in response to that kind of really juicy question about what does it mean to be peer-led, peer-run, or to have peers, I really think what we're getting at is that some organizations require that their leadership have personal lived experience with mental health challenges, be consumers themselves, right? Whereas other organizations function in a way where a parent organization, they may hire peers into specific roles, but that the organization itself is not led or directed or designed by people who have lived experience. So I do think it's a really important distinction, and I would second the suggestion to add some of that into the pillars.
Thank you, Sarah. Yeah, and I would just add that that's inclusive of substance use organizations as well, right? There's a lot of peers in substance use organizations. A lot of their leadership are in recovery themselves as well. I think important to hear this feedback. I think the intention was to try to capture that in the fourth bullet, lived experience and community leadership, but helpful. Thank you.
And I think that was our last commenter. Oh, we have one more. Patricia, your line is unmuted. Go ahead.
Hello?
Yes, we can hear you.
Okay, thank you. I come from Napa County. I'm currently on the Napa County Board of Behavioral Health, which was an integration of the Mental Health Board and the ABAD, which was the Advisory Board for Alcohol and Drug or Substance Use Disorder. And in Napa, we have an Innovations Community Center, and I'm just wondering if that's what we're talking about type of thing, or is that not what we're talking about? That would, without going into it, that would be some clarity there would be helpful.
I don't know enough about the Napa Innovations Community Center to know. Sorry.
Okay, if I could add, I'll
Patricia?
just read a little bit. The Innovations Community Center is peer-staffed mental health program, although it does have substance use, is really behavioral health, not mental health. Supports individuals from underserved communities. The center explores the complex interplay between mental health services, aging, poverty, race, immigration status, sexual identity, and substance abuse. The center promotes collaborative relationships between recipients of mental health services and mental health and wellness practitioners throughout Napa County. Practitioners and service recipients work together to foster healing through storytelling, artistic expression, healthy living, spiritual practice, and social connections. The members of the innovation community participate in support groups, one-on-one coaching, work experience, and volunteer opportunities.
I wonder if this maybe was an innovation project through the MHSA.
I don't know. I know it's funded at least partially by the county. I don't know where its
Okay.
total funds come from.
Yeah, and I think even just hearing that is like what kind of components of that might help to think about how, things that might be useful as we put together this grant concept.
Well, it can be found, more information about this one could be found on Innovations Napa County. It pops up, but what my concern is I know people who were unhoused but have achieved housing recently, relatively recently, and still have difficulties maintaining housing to some degree. They could lose their housing again. They benefit from this program. I wouldn't want them to be excluded because they have housing currently. They also have serious mental health, SMI, and I see what they benefit from, just like art therapy or something, if they're not able to go back to work for financial gain or even maintain a significant volunteer status.
Thanks, Patricia.
Thank you.
Thank you.
And it sounds like that population that you're describing is exactly kind of those priority populations that are laid out in the statute.
Our next commenter, Michael. Michael, your line is unmuted.
Yeah, can you hear me well?
Yes, we can hear you.
Yeah. I apologize. I didn't get the handouts early for me to go through the list, but I was wondering between the three pillars and this 6 bullet points here. I don't know what to add this to. One of the things that I want to bring up is the idea of skill buildings in terms of recovery skills, right? Many times we talk about providing services to our clients. Most of the time, not absolutely always, but most of the time, the counties are focused on help with removal of the symptoms, whatever the particular symptoms is, to help them get better. And once the symptoms is removed or subsided, they're basically kind of left on their own with some supportive services, but not that much emphasis on skill building in terms of recovery skills, because it's through daily practice of recovery skills that helps our clients get better. And it has to be a daily practice, right? Whether it's being more cognizant of wellness recovery action plan, being more cognizant of cognitive behavioral skills or dialectical behavioral skills, and the list goes on. And being aware also of one's motivation to get better, which helps them to keep them practicing the skills. And it helps not only in prevention and early intervention when we teach our kids or the youth in terms of recognizing their wellness, and perhaps funding projects that teaches wellness delivery skills in terms of when they feel that they are not well, how do they get better? Where should their thoughts be thinking and things like that? So I guess what I'm saying is that we need, and I don't know where to add this, is that we need to add more emphasis in terms of teaching recovery skills and help them, and bring in the peer support system to help them practice their recovery skills so that they can maintain their wellness.
Thank you, Michael.
And that looks like that concludes our commenters. Oh, we have one more. Rachel, your line is unmuted. Go ahead.
Hi, my name is Rachel Steidel. I'm the Executive Director of Youth Well in Santa Barbara County. I just wanted to comment on the public-private partnerships because I'm really happy to see this on there, and it's something we're advocating for in our community, which is, I really don't believe we're going to be able to change or move the needle if we're not investing in our private partnerships and looking at private therapists and figuring out how to hold insurance companies accountable and making sure that we are supporting families and learning how to advocate for resources they should be getting. So I just appreciate seeing that on this list.
Thank you.
Thank you, Rachel. Okay, I think that concludes comments. Okay, I'm going to turn this back over to you, Sarah.
Okay. All right, well, we'll go to the next slide, which you have seen before, not this one, but the next one. You've seen this before. So this is the timeline slide that we looked at earlier. So just walking through it again, you can see where we are in terms of our virtual community engagement session. Our next meeting is actually August 13th from 3 to 5. You all are welcome to join as well. We'll have a virtual community engagement session in the future, and then the program advisory committee meeting, as we talked about in the commission meeting. So just look forward to having additional feedback from you all. If you all have additional feedback that you think of following the meeting, certainly welcome any feedback in writing as well. So look forward to hearing from you all and continued conversations with you. Brenda or Chairman Tsai, any closing words or comments?
I mean, just appreciate the feedback received today. We've been taking notes, and we really do look forward to continuing this conversation. Brenda?
Yeah, Sam, I really appreciate the time everybody took tonight to spend with us and share your thoughts. And I think we got some great notes and great input today. Oh, it looks like Patricia had one last parting thought. Maybe we can grab that before we leave.
Your line is unmuted. Patricia, go ahead.
Just the address to write if we had a comment.
Oh, okay. Melissa, Grace, do we have something? And I know we don't have chat going, so, or maybe we can we email out to everybody if they have follow-up?
Yep, there's the program committee email is on the meeting agenda for today. If you but we in any of the registration emails, you'll also find a link to email us directly. And it's just program@bhsoac.california.gov. But it's written down.
Okay. Do you have that, Patricia?
One more time, please.
Okay.
course.
One more time, Ms. Callie.
It's program singular
Uh-huh.
at BHSOAC.
Thank you. That's it, right? Dot,
Don't forget don't forget the .california.gov.
oh, dot,
.ca.gov.
Thank you so much. I appreciate that.
Thanks, Patricia. All right, so I think that wraps us up for today. Again, big thank you to everybody. We've got 2 more listening sessions. It's pretty much going to be the same information, but everybody's welcome to come if you have more thoughts that you want to share with us or just want to tune into the conversation, because they're great conversations, but in terms of trying to hear the progression of the thinking. But really want to wish everybody a great night. Thank you so much. Thanks, Dr. Tsai, for and to I don't know if we still have Commissioner Chambers online too, but to our commissioners for showing up today and for our amazing staff team here at CBH. We had Melissa and Callie and Grace who did a great job helping keep us on track and pop us all over the place on slides so we can have a good conversation. So thanks, everybody.
Thanks.
Thank you so much.
Have a great night. Bye-bye.